Everybody, today I'm presenting Dr. Tomek Piorkowski. He's a haematopathologist working at Pathcare laboratories. He qualified in laboratory haematology in 2023 and briefly worked at the South African National Blood Services before moving to Pathcare. Prior to specializing, he worked as a GP in various private healthcare or in various private primary healthcare roles. He also lectured part-time at the University of Pretoria. His interests include consultative, haematology, laboratory quality improvement, as well as morphology. Today's topic is reactive lymph nodes. Tomek, we're looking forward to your presentation. Thanks.
Thank you for the kind introduction. So this topic came from a query on one side from a clinician who was asking, what am I supposed to do if the pathologist says lymph node is reactive? So just a caveat, 80% of haematopathologists in the world look at lymph nodes. I'm part of the 20% that don't. It's a bit silly because in my training I had to learn a lot about the theory of lymph nodes and lymphoma. So I hope one day to do some sort of bridging course so I can be a proper haematopathologist and look at lymph nodes, but I'm talking more from textbook knowledge and theory in this presentation, but I hope it will still be quite useful. So this is I want to briefly go over lymph node anatomy. This is a diagram I used when I was studying for my part 1, which I thought was quite useful. Lymph node is surrounded by a capsule and it has the efferent and afferent lymphatics. So subcortical, you have things called follicles, and you have your primary follicles and your secondary follicles, and this is where the B cells call home. And the follicles can also be divided into a germinal center and a mantle zone. Then between the follicles, we have the paracortex, and this is where the T cells, this is mostly populated by T cells. And then we have medullary cords, which is populated by a mixture of lymphocytes, plasma cells, and macrophages. And although we say it's mostly B cells, mostly T cells, in reality, some cells are constantly moving up and down and circulating through these areas. So they're predominantly B, predominantly T, rather than exclusively so. So this is just what we see on histology. Cortex, and then we have the follicles, and the areas in between are the paracortical areas, and our follicles, when they are activated, they'll have a dark zone and a light zone. So what's happening when in those zones? What happens when a lymph node is reactive? So as I said, you have the resting B cells that are in the follicles, you have resting T cells in the paracortex, and you have the macrophages, and you have the sinuses. And as I mentioned, cells are constantly circulating in and out of these areas. So these are predominantly B cells, but they're not exclusively B cells, and the same for the other areas. When there's an immunogenic stimulus, those cells that are wandering about get activated, and that causes a chain reaction, which we'll look at in the next slide. And this causes lymphocytes to proliferate and to recruit macrophages and histiocytes, and that population also expands. And as the lymphocyte and histiocyte population expands, the lymph node swells in size. And the goal of all of that is to create a plasmablast that is the best fit for the antigenic stimulus. And that plasmablast will proliferate to make plasma cells and memory B cells. The other cells that didn't go through, make it to the end of the process will apoptose or downregulate, and as they die off, the lymph node returns to its previous size. So diagram illustration. So the antigenic stimulus floats into the lymph node for lymph fluid circulation, and in the paracortex, that's predominantly T cells. The T cells will activate, and then wandering B cells and the dendritic cells will also activate. And you need all three to be activated to activate each other to generate an immune stimulus. And the reason we have this three-step mechanism is that it reduces the risk of autoimmunity. So once you have a stimulated B cell, it then becomes an immunoblast. The immunoblast will then migrate to the cortex, where it then becomes a centroblast. and it divides into many clones of itself, many centroblasts, but all of them are slightly different from each other. So they undergo a process of hypermutation. The centroblasts then interact with follicular dendritic cells, and the follicular dendritic cells take up the antigen and then compare how well the antigen binds to the mutated centroblast. And the ones that bind very well get to live, and the ones that do not bind very well die off. And this will then, this area of the lymph node is called the dark zone, because all these proliferating centroblasts cause the sort of density or the darkness of that part of the follicle to increase. So centroblasts that survive this process, the remaining few will go on to become centrocytes, whereas the rest will then be stimulated into going apoptosis and be eaten up by macrophages. The centrocytes that survive will be stimulated further by dendritic cells and T cells to differentiate. They'll either become memory B cells that will circulate through various lymph nodes and will only be activated on the next stimulation with that antigen, or they become plasma cells, which will initially generate IgM, but as some of them also differentiate, and on the later stage you'll get your IgG and your IgA and so forth, and they will also migrate to different areas of the body. So that in a nutshell is the stimulus of the cascade from B cell to plasma cell. So just going back to this picture that we'll see, this is where you'll get your immunoblasts formation. They'll migrate to this area where they'll become centroblasts, and then here they'll become centrocytes, and then they'll eventually become plasma cells and migrate out of this area. So there'll be stimulation of growth of B cells and T cells as well, causing the lymph node to swell up during this whole process. So when the pathologist looks at the lymph node and decides it is reactive, he should ideally tell you where is it reactive, because that's going to help you decide what are the likely causes of this reactive picture. There's a reactive follicular hyperplasia, and that was predominantly a B cell hyperplasia. Reactive paracortical, predominantly T cell. Reactive sinus hyperplasia, and that was predominantly some histiocytes that are reactive. And then you can also get a mixed picture. But if a pathologist says this is a reactive lymph node, he needs to state in the report where is it reactive, because that's going to help you minimize, get your differential diagnosis in a better place. So you can call your pathologist and ask them, like, where is it reactive if they haven't mentioned it in their report. Starting with reactive follicular hyperplasia. So this is where you have large hyperplastic follicles with very prominent sort of dark and light zones. And it's characteristic of stimulation proliferation of the B cells. And it's usually involves lymph nodes, although extranodal lymphatic tissue can sometimes also have reactive follicular hyperplastic features. And what kind of patient would present with a follicular hyperplasia? They're going to have the enlarged lymph nodes, and they can be localized or even generalized. The lymph nodes are typically tender, and they typically will have systemic symptoms or full blood count abnormalities associated with infection or inflammation. The location of the follicular hyperplasia can help you narrow down the diagnosis. So, for example, cervical lymphadenopathies with follicular hyperplasia is associated with infectious mononucleosis. In the posterior cervical area, think of toxoplasmosis. Parotid and submaxillary epitrochlear is associated with HIV. Cervical axillary, think of cat scratch disease. And if it's inguinal, it's STDs. There are other causes, though, of reactive follicular hyperplasia. For example, a variety of drugs, chemicals, and environmental pollutants can also cause this picture. Zooming out for the sort of specific anatomical areas, other bacterial causes of reactive follicular hyperplasia include syphilis, toxoplasmosis, your viruses, your HIV, EBV, and measles. And autoimmune diseases can cause reactive follicular hyperplasia, in particular rheumatoid arthritis, Sjögren's syndrome, and the IgG4-related sclerosing diseases. There's also a benign lymphoproliferative disease called Kimura disease, which can mimic a malignant process. So the pathologist needs to be a bit careful with this one, but this is a the prominent sort of idiopathic B-cell growth. There's also progressive transformation of germinal senses. This is where you have a reactive follicular hyperplasia due to a stimulus outside of the lymph node, and often there can be a malignancy. So you might have a lymph node draining an area where there is malignancy, and as part of the reactive process to that, you have very, very big germinal centers, and that's for slight disorganization of the architecture. However, in many cases, the cause of the reactive follicular hyperplasia cannot be identified. This is a picture showing what the pathologist will see when they see reactive follicular hyperplasia. So typically, you only have a few follicles under the cortex, but here we have big, prominent follicles all over the lymph node and very prominent mantle zones. However, the architecture appears to be preserved. There's no invasion of cells in and out of the germinal center. Then we can have reactive paracortical hyperplasia, and that is predominantly a T cell immunological response. And it can occur with follicular hyperplasia as part of a mixed picture, or it can occur in isolation. So these patients present with localized or widespread lymphadenopathy. They may have systemic symptoms. The lymph nodes are mildly to moderately enlarged. They're usually not matted. There might be a laboratory abnormalities such as leukocytosis and lymphocytosis, and there's frequently another disease on board, such as autoimmune disease or malignancy. Other causes of a paracortical hyperplasia include your environmental pollutants and chemicals and drugs. Your anti-seizure medications, in particular epinephrine, are known to cause reactive paracortical hyperplasia. Vaccine administration can also cause this, usually about 1 to 3 weeks after vaccination, especially documented in smallpox and measles. And in viral infections also, such as Epstein-Barr, CMV, and herpes simplex. This is a picture of a paracortical hyperplasia. You'll see the follicles are almost invisible, so we don't see those nice little circles. It's just the tissue in between the follicles is so dense and hyperplastic that they've essentially drowned out the follicles. And we have the sinus hyperplasia, and this is when there's predominantly histiocyte prominence. It's associated with infections, neoplasia, and surgery. And we'll see that here are the lymph node sinuses, and the macrophages around the sinuses are particularly dense, and the smaller cells are the lymphocytes. But this is quite a prominent increase in histiocytes. All right, so at the pathologist level, what are the things they can do to make sure that this lymph node you decided to biopsy is definitely benign? Because surely you wouldn't have gone in for a lymph node biopsy if you were worried. Unless you were worried that there was something malignant going on, something suspicious. The pathologist is going to look at how the lymph node looks macroscopically. So, and if they are soft with a tan homogeneous surface, that suggests a benign lymph node. If they look at the follicles, the parafollicular area, sinus areas, and they can all each area is recognizable and looks sort of like clearly as it looks in a textbook. We say that's the patient has preserved architecture. So that also is more in keeping with a normal lymph node or reactive lymph node. You see the pathologists for a lymph node, they often do a whole battery of immunohistochemistry stains, and after looking at those stains, they'll see that the patterns are all normal. You can do lymph node flow cytometry that is offered now by special arrangement. You need to put the lymph node, I think, in saline and send it to our referral lab. And that can be normal. And then you can also do IgH and TCR on the lymph node tissue, and then very sort of very sort of borderline cases, you can even do FISH and genetic tests on the tissue to properly confirm that this is a benign thing and not a malignant thing. And then I saw some beautiful pictures of thinking of the differential diagnosis based on surface anatomy, and I just had to share them because I thought this was quite lovely. But if you've done a biopsy and it says it's reactive, you can think, where did I take this biopsy, and what are the differential diagnoses based on that? Preauricular lymph nodes. The benign causes are the scalp infections and mycobacteria infections, and then neoplasms and lymphomas and head and neck cancers are the non-benign causes. For the submandibular area, mononucleosis and upper respiratory tract infections, various viruses and mycobacteria, with the malignancies causing this lymphadenopathy being the squamous, the head and neck cancers, lymphomas, leukemias. Anterior cervical nodes, differential diagnosis is the same as the submandibular. Posterior cervical nodes, same as the preauricular. The subclavicular nodes drain when due to thyroid or laryngeal disease and mycobacterial fungal infections, but they can also be, swell up due to thoracic or abdominal malignancy. The infraclavicular nodes are particularly worrisome if you can feel those nodes. Those tend to swell up with non-Hodgkin lymphoma. There's not many benign causes of infraclavicular lymphadenopathy. Axillary nodes can drain from a number of infective and or autoimmune causes. Malignant causes are due to the breast cancer, skin neoplasm, lymphomas, leukemias, sarcomas. Your epitrochlear nodes can be due to lymphoma, but also can be from skin infection and skin malignancy. And then the inguinal node is, the inguinal nodes are a bit challenging because they swell up very easily, typically from STDs and skin infections. But in my experience, they can swell up due to any inflammatory stimulus in the body. So when I was a registrar, there was a patient with massive lymph nodes all over the body. They did a bone marrow and an inguinal lymph node biopsy. Inguinal lymph node biopsy was reactive. The bone marrow was very malignant, but it was the architecture of the marrow was so fibrotic, it was hard to say exactly what malignancy it was. And this was just before December, so the surgery clinic was closed. Patient came back only in February. Then they decided to do a biopsy of the cervical node, which showed Hodgkin lymphoma. It just shows how sensitive inguinal nodes are to inflammation anywhere in the body. And you should always avoid biopsying an inguinal node if you have another node that you can biopsy. If there's a lymphoma in the immediate area, you'll see that lymphoma, or if there's malignancies of the genital area or the skin in that area. And with the vertical inguinal node group, you need to think also of the anal canal and the vagina. Okay, so now you can also have medication-induced lymphadenopathy, as I mentioned, and this is the list of drugs that are most strongly associated with causing lymphadenopathy. So we have an allopurinol for gout. We have some of our antihypertensives. We have our anti-seizure medications. We have some of our modifying disease agents, penicillin, Actrim. So a wide variety of medications that can cause a benign, generalized lymphadenopathy. So if you see a pathologist report and it says that the lymph node has reactive lymph node changes, interrogate the report or the pathologist, ask which part of the lymph node is the reactive area. Think about which anatomical area did the node originate from. Are you happy that the biopsy you did is representative? So for example, in that patient that I mentioned, that inguinal node biopsy was not representative of the disease. Do you need to biopsy another lymph node? And does the patient have medications on board that might be causing this lymphadenopathy? Of course, you want to avoid biopsying benign lymph nodes. So you also have, you need to think about when to biopsy a lymph node, when is it more likely to be malignant rather than benign. So age about 40 is associated more with increased risk of malignancy. The node is greater than 2 centimeters in diameter. If the node is not returning to baseline after 8 to 12 weeks of observation, generalized lymphadenopathy is more worrisome than a localized lymphadenopathy. Male patients are more likely to have malignancy. The periclavicular location is more likely to be malignant. If there are B symptoms, and as fevers, night sweats, weight loss, or if you can palpate hepatosplenomegaly. If there are cytopenias or bruising, if it's not tender, that's a bad sign. If they're very hard and rubbery and matted, those are bad signs. If they're increasing in size, also avoid biopsying in the inguinal area. Go for the axilla or the neck if possible. Now, what kind of lymph node biopsy do you want to do? An FNA or core biopsy or an excision biopsy? And especially, this is particularly with reference to lymphomas. So surgical excision of the whole lymph node is a standard of care for lymphoma diagnosis, but it's not always feasible. Core needle biopsy is quicker and cheaper, but your yield is going to be about 92%. So we say lymph node surgical excision is 100%. You'll diagnose 100% of your lymphomas. Your core needle biopsy is going to be 92%. You might need to end up doing a surgical excision anyway. And FNA is the cheapest and the quickest, but the sensitivity is only about 85%. So you're going to miss about a quarter of your lymphomas doing FNAs as your primary sort of diagnostic modality. And why is that? So this is in the article that I was reading is referred to it as the keyhole problem. That when you do when you don't do an excision biopsy, you are looking through a keyhole at the lymph node. And to diagnose malignancy in the lymph node, you need to see the malignant cells, and you need to see what they are doing to the architecture of the lymph node. Is it predominantly in the mantle zone, in the follicular zone, in the paracortical areas? Is it diffuse? So if you do an excision biopsy, you're sort of gambling that you are going to take enough malignant cells that you can say there's malignancy, and that you've got enough architecture in the area that you biopsy to say what type of lymphoma it is. If you happen to biopsy a less optimal area, you might see the malignant cells, but you won't get enough of an idea of what they're doing to the architecture to say what type of lymphoma it is. And if you're unlucky, you might do an excision biopsy of a completely normal area of the lymph node and completely miss the lymphoma. And with an FNA, it's even worse, because with an FNA, you don't see any architecture. You might see the lymphoma cells, but you won't. It'll be challenging to definitively type what kind of lymphoma you're dealing with. And with an FNA, it's very easy to completely miss the lymphoma and only biopsy normal tissue. Right, so that was, I think, perhaps a bit basic, but I think sometimes it's a good idea to revise the basics. And that was the approach to how to think about reactive lymph nodes, and how to sort of think about the further diagnostic differential diagnosis when you're faced with a pathology report that says this is a reactive lymph node.
Thank you so much. I don't think that you have simplified so, but it's not. I think based on your presentations, I think probably clinicians we misunderstood when the lab results say reactive. So obvious on the clinician side of it, that no, for most of my colleagues, reactive means stop, move on, observe. But actually, that's what the results didn't say based on your presentation. Basically means that look for something other than malignancy. Okay, means somehow you have to go through your drugs, you have to go through all the lists. So it's actually open up the can of worms to saying, let's go into more details, look at the patient holistically, and then let's look at external, internal factors that might contribute to it. And basically that's what we have done. And I think for me, this is really quite a big presentation that actually probably intern, medical officers, physician, they need to kind of revise it again, and I think for me we have a case that we saw recently, was really a young nurse that came with young lung lymphadenopathy, And obviously, the first result was a reactive lymph node. And then after a few, and then I think a week later, Nasima went and did some staining and said, actually, no, it's not. There's kind of a cushy cells. And another bit because, oh, what is that? So always, I think there's a particular cost to it. So I don't think that reactive means reactive. Reactive means somewhere redirections to other part and try to look at a different kind of perspective for me. I don't know, Leanne, what do you think?
Yeah, I think it is. I mean, it's typical, like the example you gave, where there can be lymph nodes everywhere. But if you don't make a intelligent choice about where you're going to take the sample from, you're not gonna. You can miss the main diagnosis and write it off, basically.
Well, also, I think the most important highlights about the supracerebral lymph node. I think we have a patient. I don't know whether it's in the ward or not. Kelly Kruger. That patient, I think the patient that come with the right lymph nodes, I don't know where the biopsy is done, but just for a male in their 50s. Obviously, it's quite a lymph node, so it's very small, but irrespective of how it is, most of the time it's very significant.
Yes.
Because on the right side, most tell you about intravenous pathology, lung mediastinal, whatever could actually contribute to it. So sometimes in biopsy become a key factors, but obviously I think they're always concerned about surgeons who, when they do the biopsy does not mean that you remove the lymph nodes. You just really need a piece of it, isn't it? To send for saline and for histology, then so they can get diagnosed. Because sometimes resecting the lymph node totally also you do play with anatomy. You kind of cause anatomical destruction of the area. Yeah, so I think there are certain areas that you need to biopsy, especially the supracerebral lymph nodes, of course. Axillary, you always have to check you have to look at the size and always look at whether it's mobile, whether it's hard. When it's rubbery, sometimes you can observe it's less than 2 centimeters. So I think it's very good to have insight into that. And most, So basically, the absence of hematological pathology on the lymph nodes does not exclude drugs, does not exclude other contributing factors like lupus, autoimmune, what's systemic autoimmune rheumatological disease. It's no longer its connective tissue. So you always have to look into that. So I think you have to really trigger more workup, isn't it? Into much more detail. So sometimes worth not to stop. And then reactive lymph nodes, is there a role of bone marrow BMET? Do you think it's helpful or it's not helpful? Can they go together? Because sometimes a physician is very obsessed, we're worried. We think we're missing something in the hematological because the lymph node that's with the hematology, and you kind of feel like, no, there's something still having bone marrow. And typical of me, of course, I like to do that to make sure that the bone is normal.
Okay.
How realistic is that? Or Michelle, you can chip in. I think you're the silent hematologist sitting next to. Yeah.
No. Well, I think you have to look at the picture in whole. I mean, if there's malignance suggestive or B-sign symptoms, rather do a marrow, or else you can observe the patient, exclude viral infection, see it maybe worsens within 2 weeks, and if you think it worsens, you can actually do it.
But also, I mean, is there? I mean, if we say B cells or T cells, will that actually guide you to the source of your problem, of the patient problem, isn't it?
I mean, if there are no cytopenias, then unlikely. If you have a benign lymph node, you might be hunting for granulomas or sarcoidosis. There might be. So definitely not your first line treatment, but certainly if there's an unexplained process that you need to diagnose, sometimes you'll be lucky doing the bone marrow. Also, while we're on the topic, bone marrows are often used as a sort of substitute for lymph node biopsy, especially if there's lots of intra-abdominal lymph nodes. So sometimes we're lucky, we'll see malignancy in the bone marrow. But bear in mind that only about 1/3 of lymphomas involve the bone marrow. So sometimes you still need to do that biopsy. But so yeah, as Michelle said, you need to look at the whole picture and ask yourself, what am I looking for? Because sometimes weird, funny diagnoses can be found on a bone marrow. It's not, most of the time it's there's nothing there. Certainly, I think if you have a reactive lymph node, look at your medications, look at where the lymph node was reactive, look at the whole picture and decide what is more likely, toxoplasmosis or EBV, or is this some patient with systemic unexplained symptoms? That's we can do a bone marrow biopsy. Maybe we'll see granulomas or something that will not necessarily primarily hematological, but will point you into a thing.
Yeah. So benign does not mean that you must stop. We just basically that change your train of thoughts and consider other perspectives. Yeah. And then the context of retroviral disease with HIV, obviously workup would be more pointing toward that, it's more HIV related illnesses, But also, I mean, let's be honest, because we concerned with, I think the university levels are no longer the same as previously. Means the training probably is not, the standards gone down a bit, but the chance that actually pathologists miss label as a reactive than that. Is there any histochemistry markers that we could say, okay, this is a good report, this is a bad report? Is there a way that we could look into that?
Oh, that's an excellent question. And I think as a pathologist speaking to a clinician, and as someone who doesn't look at lymph nodes regularly, as part of his routine work, it's going to be challenging. But you'd want to see on the pathology report that they did a CD3 and a CD20, and they should.
Nobody's done though, too.
Yeah. And then typically, it is follicular hyperplasia. They should do a BCL2. And they should describe whether the cells are small, if there's any suspicious looking cells there. You're always welcome to ask for a second opinion. If you strongly think there's a malignancy and you want a second opinion, sometimes you just need a second opinion.
Yes.
There are numerous sort of borderline areas where sometimes it looks more reactive, but it's actually malignant, or it looks malignant, but it's actually reactive. So it's if you strongly feel that this needs a second look, you can ask for a second opinion and just say, do you think this panel is sufficient to exclude malignancy? And look at sort of fine. I think with Pathcare, because all our slides are accessible digitally, it's quite easy to get a second opinion. So, I mean, I can even go on my laptop and look at the lymph node. Not that I'm a lymph node pathologist, but I can go and look at it, give you my opinion as a South African trained hemopath. So, yes, if you strongly suspect this specimen needs a second opinion, I would encourage you to say, well, not doubting your skills, but I just want a second pair of eyes to confirm.
Yeah. Okay. Anybody online, Dr. Okoli?
Good morning. Great presentation. No question from my side.
How many reactive lymph nodes do you get in your practice? Do you see that more frequent? What do you do when you saw them? Do you go ahead or you just relax? Do you think this presentation has changed your way about to look at the reactive lymph nodes?
Yes, definitely. I think it's more like patient specific. So I kind of try to evaluate further depending on the presentation. But a lot of times you see those that end up being malignancy. Yeah. Very few reactives, mostly malignant.
Thank you. Anybody online before we say goodbye? Kelly, any comment? You're writing exams? Do you understand your B cells now, T cells, dendritic cells?
No, thank you. It was a very nice overview of my pathology. Thanks.
All right. So if you have no questions, I think well done for saving us time. It's a very good presentation to the point. Thank you so much. And we would like to welcome Dr. Godinius. He's back. He finally appeared. Welcome.
Thank you.
So yeah. Thank you.
Next week, Dr. Jim